Thank you so much, Katie, for meeting with me today. And before we start, please could I ask you to introduce yourself and your role?
Absolutely. So I'm Katie Malbon. I'm a general paediatrician at Imperial, and I have a special interest in adolescent medicine.
If I may introduce myself, I'm Dr Liz Hare. I'm a GP. I started my medical life in surgical training, which is some of the interests that I have in case reviewing for NCEPOD. I worked on the Inbetweeners study, and I also am a member of the Royal College of GPs Adolescent Health Group. And as the Adolescent Health Group, we were looking to spotlight some of the barriers and obstacles to delivering young people's healthcare at present. And that's why we've chosen to meet today to talk about the Inbetweeners report. So firstly, if I could just ask you, could you tell me about NCEPOD?
So NCEPOD stands for the National Confidential Inquiry into Patient Outcome and Death. It's an organisation that's been going for 30 plus years. And what they do is carry out sort of reviews of often sort of pathways of care, looking at examples of good practice and also where it's not going quite so well. And the process is done largely by case note review, but also questionnaires to clinicians, to patients, patient carers and parents, to GPs. So you get the sort of holistic view of patient care. And typically it would look at a single pathway. I think it was, a bit of a challenge when faced with transition, because obviously it's not a single pathway, it's an interweaving of many different pathways. So this was quite a difficult subject to tackle, but actually once we got stuck in, we realised that we could actually get a lot from it. So I think we hope come out with a good report with some quite robust recommendations.
So again, for clarity, the Inbetweeners report refers to transition. Now, not everyone in primary, which is the general healthcare sector, secondary, which is hospital sector, and tertiary healthcare, which is the specialised hospital setting, completely understands what transition is. So could you please just explain that for me?
Absolutely. So transition is often misinterpreted as the transfer from children's services to adult services. But actually, transition is a whole process during adolescent years. So it starts at the beginning of adolescence, between 11, 12, 13, and it's a process whereby a young person starts to understand their own healthcare needs and becomes empowered to then manage their own healthcare as adults. So they're going from their parents sort of managing their healthcare and their healthcare needs to them understanding it and managing it themselves. And in order for transition to happen, it relies on healthcare professionals engaging young people in a developmentally appropriate way. So transition and developmentally appropriate healthcare go hand in hand. They are one thing. So I think that it's really good to clarify that, because it's so misunderstood, and it's important that we get it right.
Why is transition so important for our young people?
So, I think generally adolescents are a sort of missed group of people, of individuals where there's a lot of opportunity to improve their healthcare, not just during adolescence, but obviously how their healthcare is managed as adolescents will impact on them as adults. Mm-hmm. It's a time where their brains are still developing, and because of that, they are more at risk because they don't necessarily understand the consequences of their actions. So it's a time when there's lots of risk-taking behaviours happening. It's also a time where chronic diseases are often diagnosed. So, our diabetes, inflammatory arthritis, there's chronic illnesses. So it's important that they have an understanding of their disease and how to manage it during the adolescent years. And then it's also a time where mental health is pretty fragile and vulnerable. So they have so many challenges. Not only are they changing physically as they're going through puberty, but they've got issues regarding relationships, both with their family. So it's a time where they move away from having such a close connection with family to friends becoming more important, and then to having sort of intimate relationships as well. So the challenges of managing those relationships. At the same time, they are in education, and there's a lot of uncertainty. So, they're doing public exams, there's a pressure around exams, and I think the stress or anxiety of not really knowing where they're going to be in the next few years. So, are they going to make it to university? Are they going to be working? Are they going to be living at home? Are they going to be living abroad? So there are so many unknowns that it causes them to feel, I think, very vulnerable. And, it's anxiety producing, isn't it? When you've got that feeling of not knowing what's going to happen. And so it's really important, I think, that we make the most of any opportunity that we have with a young person, an opportunity to deliver some health education, some support, some knowledge, and empower them going forward. So, and actually the other thing to say is adolescents, they're generally healthy during this time period. So they don't necessarily have much interaction with healthcare. So when they do, we need to kind of grasp that opportunity to impart some knowledge. And we also need to be letting them know how to access services, because it's not something that we do very well, really. And making a GP appointment can be quite a challenge as an adult. So, an adolescent can find that really, really difficult. But also sexual health care, how they access sexual health centres, and mental health. That's also very challenging, and where they would go. There's less stigma around mental health, I think, than there used to be, but it's still challenging to know where to get the right help.
Thank you so much. You've really described the multiple factors that an adolescent or young person is experiencing as they navigate that part of the journey. And you've alluded to the ways that it can go wrong, and where a young person can effectively sort of fall between the cracks, and that we should, as healthcare professionals, be only too aware of that and mindful of it. So just very simply, over 46,000 young people with at least one of 12 specified chronic conditions were identified between the time frame of the 1st of October 2019 to the 31st of March 2021, which, as we know, is the time of COVID. And over 1,000 of those young people were selected for inclusion in this study. As you've already said, the 3 data sources that were reviewed were the young person's case notes as they navigated the journey from primary care through various specialties and agencies around them, and the clinician questionnaire, which was sent to the nominated secondary care specialist for the main condition, and also primary care questionnaires. So this is a very significant body of evidence to really, really look at what has happened to that young person with the condition through that part of their lifetime. So if we just move on forwards now, please could you tell me some of the key findings and recommendations of the Inbetweeners report?
Well, so the overall finding was that the quality of transition was really, really poor. So more than 50%, it was not adequate. Well, I mean, that wasn't really much of a surprise. There were sort of 5 key recommendations that came out of that. The first being to try and make developmentally appropriate healthcare core business. So, our problem at the moment is that it's sort of seen as an additional thing to do, and no one has time. And whose responsibility is it? Is it paediatricians? Is it the adult services? Is it the GP? Is it, so that's quite difficult in an already pressured NHS. But if we can educate that actually, what we do initially, although it might take a little bit more time, will be both time saving and cost saving in the long term. So it's sort of getting that message across. And so making sure that people understand what developmentally appropriate healthcare is. And I think people struggle with that because it's quite simple, really. It's approaching young people in a way that they will understand. And that might not be what you would do in paediatrics, and it might not be what you do in adult services, but it can be simple things like seeing young people out of school hours, seeing them in an environment that is more adolescent friendly, writing letters to that young person rather than their parents. And a lot of that is around making that young person feel understood, and that you're sort of on their level. It is largely about educating healthcare professionals. And then a second recommendation was about involving young people, parents and carers in transition planning. So sort of managing their expectations. So a lovely example of this that we saw was a young person who he had complex needs really under several specialties. But his transition had been so planned with him involved. So he knew from quite early on what transition was. He had a written transition plan that was also available on his phone. And when he was in sort of crisis, he would attend the paediatric emergency department, and he would be able to show them the transition plan on his phone and who was involved in his care. And then he knew that when he was transferred to adult services, he would go to adult ED in crisis. And he knew what that looked like. And he knew he'd visited the adult outpatient department, so he knew what that looked like. And his parents knew about this the whole way along. And that solved so many problems. Because a lot of what happens is to do with people not knowing and being fearful of the adult services when they needn't be, and that causes a breakdown in relationships, and it all goes wrong. So really important that young people are involved in that whole process and have an understanding of it. A third recommendation was to improve communication between different specialties. So particularly, as you said in the study, a lot of these young people were under several different specialties. And what we found was that they were being transitioned appropriately in some specialties, but other specialties it wasn't happening at all. In fact, it would have been much more efficient if that transition had been managed sort of in an overarching way between specialties, and everyone knew what was going on and there was no duplication. So again, about communicating, and actually, COVID has enabled us to be using Teams, and for MDTs and transition planning to be done, online, which makes things much more efficient and easier, rather than having to get everyone in the same room. Then a fourth recommendation was organise services more appropriately, both in paediatrics and adult services. So It's no good really having the paediatricians doing all the transition and then they get to adult services and adult services not understanding what transition is or what developmentally appropriate healthcare is. It has to be a continuum that everybody is engaged with and everybody understands. Having an overarching lead who will make that happen more easily. And we really found that lead person was missing in a lot of these young people's journey. So there was indecision about who that overarching lead should be. And I think the problem is it can be different depending on the situation. But the main thing is a lead should be identified. And then finally, the fifth recommendation was about leadership at executive board level. So, and I think that's really important. And I hope that the NCEPOD report will really drive that recommendation, because if it's not up there as a priority at executive level, it just can't really happen. So, and I know lots of people try and push it up there, but there's no sort of data to back that up. And hopefully the report will help with that.
I understand that you are a consultant paediatrician. Are there any tips that you could offer to primary care as we take on the mantle of transition for a young person?
I mean, it's a real challenge, and I do feel for GPs, because again, you know, I can imagine it feels like a huge hurdle, really. And I think one of the issues as paediatricians is that we don't necessarily involve GPs early enough. So particularly young people who are under, you know, secondary and tertiary care with lots of different specialties, it's quite often sort of contained in secondary and tertiary care. And the GP might just get copied into the letter, which I imagine GPs have a million letters. So, you know, but I really think from sort of secondary care perspective, general paediatricians should be actually involving GPs from early on in these transition meetings, so that GPs have an understanding of what's happening. And then it makes it much easier once that young person has transitioned to adult care for the GP to have an understanding, and they kind of know that patient from, you know, years before. It's not always possible, obviously, because there's a lot of movement, and patients aren't always in the same place and they're not always under the same GP. So that can also be challenging. But I think that's where the transition plans and planning comes into it. You know, if it's really organised well right from the beginning with GP involvement, it's going to be better in, you know, longer term. And actually, so the other thing to say is being able to identify these patients, because I think that's quite a challenge for GPs. And I do some GP hub clinics, and I did sort of propose to the GPs that if we just pulled out some of these patients, we could have a discussion around them. And the response from GPs was, well, we don't really have any. And I was like, we must have these patients. They do exist. And so it transpired that it's very difficult to find them with SNOMED codes, you know, which patients we're talking about. But when we did identify some patients, we just had a discussion around their care. It was really fruitful and helpful. And often it's quite simple things that can be put in place, or it's just recognition from both the GP and the family that this is something they can do together, which is really helpful to move things forward. So I think, to answer your question, I think it's really all about communication, and from both ways, from the GP and the sort of secondary care doctors having knowledge that they need to be talking to each other and that transition needs to happen. And the only way that can be done is by communicating and, you know, various stages along the way.
This is why I'm really glad we're having this discussion today and putting transition in the spotlight, because primary care and the electronic health systems are actually ideally equipped to identify patients who have gone through transition. You're absolutely right. There's no med codes when to do it, so it would have to be read coded. And it is, if we have the knowledge that this is a process, we can, of course, set up, a register, detail virtual multidisciplinary team meetings and interim meetings. And indeed, the primary care, who is actually a generalist, is very well placed to coordinate and organise the necessary input for a young person with an evolving medical condition. And I think that's another key point, is that this is a condition that will change or may change, and that other conditions may develop. And that's where, obviously, we work hand in hand with social care, but that's where we do need the medical side of it to recognise when input is required, to highlight when a patient has not attended and find out why, and to be able to write a referral that gives a secondary care consultant the reason why we would like a young person seeing in a timely manner. So those are my thoughts, really. And I think for those GPs who are interested, they would actually find it, extremely rewarding. I suppose my other point is that as a paediatrician, you have gone on this journey with them from when they were teeny tiny. So the other bit that you can bring is that specialist knowledge. What had been tried before? What failed? When did it go wrong? And what were those barriers? And there again, you've spoken about communication. It's about transferring that knowledge that you've already gathered about that young person to the GP, so they go, oh right, I understand now, and can work with that, and make sure plug in the right people around the young person.
And I think it works the other way, Liz, as well, that often the GP knows the family from a wider perspective. They may be known that family and the grandparents and the parents and the brothers and sisters, and so that gives a great insight into why that young person may or may not be engaging, or other things that have not been really understood suddenly all make sense. So it is definitely a two-way thing.
Okay, that's lovely. And that brings us on to the next point that I'd like to ask for your expertise about. And you've said that you work very much to involve the young person in developing their personalised transition plan. And that's a key message. So could you give me some more tips on how do you involve the young person in developing their individualised plan? Thank you.
Well, so it's a process is the first thing to say. So I have often found young people quite difficult to engage with at the beginning. And so it takes various techniques and time. But I think starting off, actually, what we haven't mentioned, the importance of psychosocial history taking with young people. So we use something called the HEADS mnemonic. So it's a structure for having that discussion, and it should be a discussion and not just a tick box exercise. But the HEADS psychosocial history, it starts with the H being for home, so asking about home, the E sort of education, A alcohol and drugs and activities, and that includes the D actually for drugs. S is about sort of sexual health, sexual orientation, as well as school and safety. So there are various iterations of HEADS, but you see the general gist is that it goes through a psychosocial history, starting with the more sort of benign questions and then asking more sort of sensitive questions as you go along. And I often find with adolescents that I see, to begin with, I might not get all the way through the HEADS assessment, but at one visit I might start to chat about school and home and pets and activities and all that kind of thing, and then in another appointment I might start once I feel I've got them on board and beginning to build a relationship with me and me with them, that you can then delve a bit more into the more sensitive issues. And so it's all about engagement, I think, and trust. And I think having, while maintaining the boundary as well, I am a healthcare professional and they are a patient, so you can't blur that boundary, but at the same time there has to be an element of trust, that they can talk to you about those sensitive situations. And you know, I always make sure that I will say I'll share information if it's a risk to yourself or others. You know, I have to be able to do that. But you know, largely what we're saying will stay within these walls. So I think as I said, it's a process of sort of gaining rapport, engagement, and then sort of understanding them as individuals. And I always sort of describe this period of time as these young people are sort of on a tightrope, and you're just keeping them safe and going along it. They might fall one way or another at various times, and that's okay, but we're still there to sort of catch them and direct them in the right way.
Mm-hmm.
And I have some adolescents who totally, you know, they've just really had a terrible time.
Mm-hmm.
And I've got parents saying this is, you know, disastrous. They're never going to manage their disease. It's all, you know, feels like it's just the worst situation. And then a year later, you know, they're off to university and they're doing really well and their disease is under control, and they look back and think, you know, how did we kind of get through that? So yes, I think it's managing expectations for both the patient and the parent. This might go wrong at certain times, but we can get you back on track. It will be okay. But it's about working together. So that is you understanding your disease, understanding what you're doing in your whole life might be affecting your disease, and the other way around, your disease might affect what is going on in your whole life too. But as long as we're communicating about it, and you know what to expect, and your parents know what to expect, we will get through it, and we will get you through the adolescent years and to be a healthy adult with an understanding of your disease.
That's a very positive message to take away from this. So thank you for that. And absolutely, effective communication is the key for enabling transition and ongoing provision for independent or supported living, as voiced by the young person themselves. So as we carry on being the tightrope guiders for the young person, I think that GPs become the glue, really.
Yeah.
I think clinically we know our boundaries with care, so we can recognise when to engage other specialties. And I think GPs also are quite good at anticipatory care, can see problems developing, and that's where regular review, be it 3, 6 monthly with an interim review, and certainly an in-depth annual review going forwards, is probably the way to look at this.
Yeah.
And why do you think that transition should stay in the spotlight? Why are we coming back to this report?
That's a good question. I think because we haven't really cracked it yet. You know, I think it's such a difficult area. And I think it's difficult largely because our services and our structures are very old-fashioned, and they're just not set up. Commissioning is not set up for adolescents. So, you know, if we had adolescents as a separate service, and commissioning as such, I think it would be done very differently, and I think that's when it will work. But it doesn't mean that we can't do anything until that happens. I do think it will happen eventually. You know, there are lots of other things that we can do to sort of mitigate that at the moment, you know, that and it can work, but there's so much learning to be done. And there are, as I said, there are areas of really amazing practice. And people are moving forward with it. And, you know, there are some trusts actually that have said, OK, we are going to prioritise this and we're going to give it some money, and some ICBs that are doing that. And we need to really sort of, you know, follow them, learn from them, and try and prove to our own trusts and our own sort of commissioners that that is the way to take things forward. I think it's very difficult. The other reason it's difficult is because there's nothing that you can actually measure that's quantitative, really. You know, there's lots of qualitative data, but there's no, it's not like there's one test that you can say, oh, we'll measure that, you know, in their late 20s, having done all this good work, that will show us that there's a big difference that means we have to do this work. Unfortunately, we can't do that. So that's where the difficulties lie, and I think it's hard to convince the right people who are supplying the money that this is where it needs to be.
I mean, one marker of actually measuring that is in inappropriate admissions or revolving door, and looking at the number of consultations that a young person might be requiring, and saying, you know, well, let's hang on a minute here, what's going wrong? So I think there are ways of looking at it, and you know, we are at obviously it is the real world, and you've mentioned incentivization. So if transition was brought to the quality and outcomes framework of primary care, and money and time was given for it, then that is a way to actually take it forwards and set aside time in a GP calendar.
Absolutely, and I think seeing it alongside that the number of attendances to ED. So recently I've been doing a little bit of work looking at how many of these adolescents present on multiple occasions and are discharged with no diagnosis. You know, and a lot of these are the adolescents that really need help. And in the same way, they're the ones that are going back and forth to the GP and they're not being given the time and this, you know, no one getting to the root of the problem. And more often than not, it will be probably a mental health issue that we're just not able to address in the right way. So you're totally right. I think you know, we all need to carry on sort of collecting this kind of data to add to you know, the weight of it.
And there have been studies looking at where adolescents end up in a hospital, and they usually end up on adult wards. And then, of course, it is totally horrifying. You know, they're between a very elderly person and a very unwell person, and the poor nurses are trying to manage all of that. And I've seen that adolescent workers that go in and talk to the young people whilst they're in can actually turn that admission around, because they have the skill set to talk about what's really going on, what's happening at home, what has broken down, why are you here today? And that is actually the way to actually develop a plan to bring that person out of crisis or out of a bad patch and get them set back on the path ahead.
Totally, and that goes back to the sort of missed opportunity, you know. So they're there. We can actually turn things around, but it's also, you know, it is a problem of inequity of care, because there's so much variability between trusts of where that is happening and where it isn't. We know it's benefits the patients, but in some trusts we don't have that service. So it's very dependent on where you are. And what policies are in place for young people within that hospital.
So if we've identified areas of good practice, then we can share good models of care, and that helps everyone involved in the process, doesn't it? It upskills clinicians, it gives them confidence, and it makes it a success. So I think we should draw this to a close now, because I know how busy you are as a consultant paediatrician, and I thank you so much for taking time out of your busy day to talk about this. I'd also like to really thank you, as I was a case reviewer, for your pragmatism and guidance through the process, for listening to the case reviewers as they discussed cases. And I think, just as we kind of wrap up, I think that the key message for me was in hearing the young person speak, and the methods that do exist for allowing that young person to say, this is what I would like to happen to me. So is there a final few words that you would like to say?
Well, thank you, Liz. Thank you for all your hard work with doing the case reviews, and it's just been a total pleasure. But I would say, you know, I feel this transition, there are so many blocks along the way, but it really is worth it, and keep going, keep chipping away. We will get there in the end. I really believe we will. But it takes a lot of dedication, and it's hard. It's time consuming. It can be very difficult conversations, but I know from hearing from young people that when it does work, it's, you know, it's the best thing ever. And we will have healthier adults if we do it right.
Thank you so much for your time today. I've taken a lot from our discussion, and I'm really glad that we're keeping transition and the in-betweeners in the spotlight. Thank you.
Thank you, Liz.